que eu tenho a honra de coordenar com o nosso decano, o professor Pedro Tauil.
Which I'm honored to coordinate. We have two speakers. Once again, thank you to the organizers. Thank you, Carol. Thank you, Daniel.
Então, eu vou pedir ao professor Pedro Tauil para apresentar o nosso primeiro convidado.
I'll ask Professor Pedro to introduce our first guest, Dr. Alexander from the Ministry of Health.
Boa tarde a todos.
Good afternoon. Thank you so much for the invitation. In the name of the Commission, thank you so much, Carol. Thank you, Daniel. I'm very honored to be here. I'm a bit outdated in terms of the research. So, for this presentation, I'd like to invite Dr. Alexander Wagner.
Dr. Alexander,
Dr. Alexander is a veterinarian doctor trained in the Federal University of Goiás. He's trained in the WebSUS, the course that the ministry provides in epidemiology. He also took his master's and doctorate in the University of Brasília, both in public health.
Atualmente, a importância dele é que ele é o coordenador.
He is currently the head of malaria eradication in Brazil. That is a big role. And it is an honor to have him here. And hopefully we'll make the best out of his contributions. Thank you.
Boa tarde.
Good afternoon. Good afternoon, everybody. Thank you so much. It is an honor for me as well. Professor Vital was my teacher in the introductory course in WebSUS as well as UNB in my master's course. Thank you so much, Dr. Claudio. So I'd just like to begin by thanking Carol, thanking Danielle as well, and to everybody, to the organizers. Thank you. All right, so we're going to talk about the overview of malaria in Brazil, perspectives and challenges, and what we've been doing at the ministry level, in partnership, of course, with states, municipalities, health districts, and many, many other partners, like academia and universities. Our history with malaria is quite long. It started in 1959. You see the SAW effect. We've reached almost 700,000 recorded cases in the 90s, around the 2000s. But of course, there are many cases that go underreported. The last 10 years, we see an average of around 140,000 a year. And in this year, 2026, we saw a significant 15% reduction. In absolute numbers, it's around 21,000 cases. This, of course, resulted from many partnerships with indigenous communities as well, which I didn't mention. So, to show how malaria moved in our country. In the 60s, it was prevalent all over in the extra-Amazon region. In the 2000s, it recruited more into the north region. And in 2024, we see red municipalities, which are where we see the highest incidence of malaria. In the left-hand side, we see the overall incidence of malaria. The red municipalities are where we have the most malaria in the country. And in the right-hand side is where we see through Plasmodium falciparum. This is from 2003 to 2025. We see a significant reduction of around 70% in the cases. So see that it has reduced quite significantly. In the last few years, the average reduction was around 140,000. And in 2025, there was a 15% reduction. An interesting image where we see hospitalizations due to malaria. The columns show how hospitalization has been decreasing in our country. And the lines show, the line actually shows deaths due to malaria. Of course, this is preliminary data for 2025, but we can already see a decrease. 2025 is a very interesting year. In every state, there was a reduction. So the state in which we saw the biggest reduction was in Acre, in the north region, 39%. So for those who have worked in Acre, and we've seen papers from Acre, Cruzeiro do Sul, we've seen up to 20,000 cases a year. In 2025, in the state of Acre, we saw about 3,000 cases, so a significant reduction. The state of Roraima is another state that saw a significant reduction, percentile speaking, and also in absolute numbers. It decreased about 8,000 cases, also due to many actions developed by the health district in partnership with the indigenous communities. So quite a significant reduction there. I will also call your attention to the state of Pará, also an interesting reduction of 19%. In Amazonas, although it saw a 3% reduction, in absolute numbers, it has a much bigger weight. So we consider 2025 quite successful. So these are the special areas that we work with. We try to classify rural areas, indigenous areas, mining sites, urban sites, settlements, and something new since last year in our training program, we also inaugurated this area, the riverfront. Before it used to just be rural, and I believe that now we will see more and more riverfront areas. There's a different approach there. And we see that in every special area, we saw a reduction, especially in mining sites, 18%, and in indigenous communities, 15%. In terms of the percentage, now in 2025, as a base year, 44% of malaria is in indigenous areas, 33% in rural areas, 11% in mining sites, in urban sites 6%, and settlements 4.6%. In terms of parasitary species, 84% is P. vivax, and 14.7% is P. falciparum. And also interesting, a 30% reduction in falciparum. We've been focusing really heavily on Plasmodium falciparum, and this result was quite positive. Please. Okay. So our colleagues from the office, they made this analysis. As of 2002, we saw an increase in cases in indigenous areas. This was a change in the malaria profile of our country. In 2025, we see a trend of decrease in these areas, but it is still the highest percentage in the current profile. So on the indigenous areas specifically, this is just to show how much we've been decreasing. In 2023, we've decreed an emergency. We've developed a lot of work in that area, and now in 2025, we saw a significant reduction in that territory.
E aqui interessante, especificamente nos distritos sanitários
And here,
especiais indígenas,
specifically in these special sanitary indigenous districts, in 2025, the Yanomami territory had 52% of the malaria cases. So 52% are in the Yanomami territory, followed by the Rio Negro territory, Tapajós territory, and Alto Rio Solimões territory. These are places of difficult access. You can only get there with a plane or with a small boat. These are very remote places that make it difficult to fight malaria. My colleague Gilberto made this map and gave me to put in my presentation. Specifically in 2025, these areas in red are hotspots that had the highest concentration of malaria in indigenous areas. Just to give you an example, this is the Yanomami territory, and this here specifically is the municipality called Amaturá in the state of Amazonas, where there weren't malaria cases for over 10 years. A couple went there. They had malaria. The place where they stayed had Wi-Fi from 6 to 8 p.m. This is the time when the mosquito was feeding, so it reached to 2,500 cases after this couple went there. This is a challenge for us. But we have been working hard, and the cases are reducing in the year of 2026. I took the data on this indigenous land to show how the work has been interesting in the Yanomami territory. You can notice that there was an increase and now a reduction, specifically in 2025. The territory of Alto Rio Negro is where we have the Rio Negro River. So we have the cities of Barcelos, São Gabriel do Rio Negro, and São Gabriel da Cachoeira. These are areas of remote access, as I said. We observed that in 2025 there was a reduction, and this is a lot of three-part work. And I joke that it's four-part sometimes. It's the Ministry of Health, the state, the municipality, and the DSE. The DSE, even though it belongs to the Ministry of Health, it has an important role as well. So with these agreements with the municipality and the DSE, we have been able to achieve the reduction in the cases. This is the Médio Solimões area that also showed a reduction. This is an increase in cases. In Rio Tapajós territory had an increase in the number of cases. So where we have malaria in indigenous areas with artisanal gold mining is an Achilles heel for us because the miners, the gold extractors, they walk around a lot. And here, where in Alto Solimões is where we had an increase because of that epidemic outbreak caused by that couple that I just told you about. Ronan made this slide yesterday, and I would like to thank him because we had to talk about malaria outside of the Amazon in a presentation in São Paulo. So I'm showing here how it was in the 1960s and now in 2024. Regarding the region outside the Amazon, we draw the attention in the bottom of the slides to the reduction of the cases in 2023, 588 cases, in 2024, 433. In the upper right-hand side, we observe the deaths in yellow in the region outside Amazon and in red in the region of the Amazon. As Aniele mentioned, these deaths outside the Amazon are a great challenge. And in 2023, the lethality of the Amazon region, region outside the Amazon was 51% higher than the lethality inside the Amazon. And the outbreaks in Piauí, Paraíba, Bahia, Espírito Santo, Goiás. So I'd like just to draw your attention that where we are here outside of the Amazon, we have to be careful as well. And what have we done in the program to move towards elimination? We have increased the use of rapid tests in Brazil. This is just to show the evolution of the procurement of rapid tests by the Ministry of Health. In 2022, we had 180,000 tests, and now we have 596,000 tests, and we are acquiring for 2026 over 1 million tests. Regarding the treatment, we use tafenoquine, which is something innovative. Now we are implementing pediatric tafenoquine, and we did in 2024 the artesunate plus mefloquine as first-line drug for the Plasmodium falciparum. Here are a few photos of our implementation, and the interesting aspect here is why the pediatric tafenoquine will be important to fight against malaria. 35% of the cases of malaria in Brazil occur in children and adolescents under 15 years old. Out of these, 56% are indigenous children and adolescents. So we imagine that now we're going to have more success using tafenoquine. And showing the latest works that we've done, the G6PD test, the implementation of tafenoquine 150 milligrams, and now with pediatric tafenoquine at 50 milligrams. And this was the note that we used for adult tafenoquine on the left-hand side, and we have a new ordinance that talks about the use for children above 10 kilos and 2 years old. Now, how do we use tafenoquine? People who test positive for Plasmodium vivax go through the G6PD test. If it is above 6 or 6.1 over, they can take tafenoquine and 3 days of chloroquine. If it is between 4.1 and 6, they do the conventional treatment, 3 days of chloroquine and 7 days of primaquine. If it is below 4 or under, they will undergo a treatment with weekly primaquine. This is just to show you how we made this decision of the implementation differently than vaccines, where you do implementation linearly. We scale this up gradually. So we had the opportunity to be closer and closer to the municipalities and going to the municipalities with the state doing the implementation of the G6PD test and of tafenoquine. In red, you can see municipalities that still have most of the burden of the disease, and the other colors are the special sanitary districts that are indigenous territories. In 2024, we trained over 2,000 professionals. We went to every city focusing on the municipalities with the highest disease burden. In 2025, we expanded this training to the region outside Amazon, with a total of 4,500 professionals trained to train them on tafenoquine specifically. The DSAs, the sanitary districts for indigenous lands, they were also trained, and this is our planning for the implementation of pediatric tafenoquine. Until June, actually until the end of the year, we have the planning of implementing in 12 sanitary indigenous districts, the DSAs. But probably here, now in June, we will be able to conclude this planning. This was the initial implementation in the Yanomami territory from 3 to 6 of March. We have this in this photo, Secretary Maria Angela, Secretary Weber, my boss, Dr. Maria Santini. This is the Yanomami territory. We went there by plane. This is just to show you that in 1 minute and a half, 2 pills are diluted in 5 ml of water. It has a sweet taste. The smell is not very good, but almost 100 children were treated, and we are still following up on this implementation. That was the Tapajós territory, the municipalities of Jacaré, Acanga, and Itaituba in the state of Pará. This is Dicey Porto Velho, Dicey Vilhena, in the municipality of Porto Velho. This week, we were in the Manaus territory, and we did the implementation in the municipality of Manaus as well. Just to summarize, how we're doing today, from 10 to 20 kilos, children are going to use 2 tablets of pediatric tafenoquine. From 21 kilos to 34 kilos, 4 tablets, but divided into 2 little cups. And over 35 kilos, this is the treatment that we started 2 years ago. 2 tablets with a total of 300 milligrams.
Mostrando, a gente já tem atualmente, isso aqui foi atualizado semana passada.
This was updated last year. We have almost 26,000 people treated with tafenoquine in Brazil. The municipality of Porto Velho is the champion with 3,300 treatments. Manaus is in second place, and São Gabriel da Cachoeira in third place. The Yanomami territory has almost 400 people treated. We contact them, we telephone them, we send emails, always trying to monitor the colleagues that are doing the work in those territories. And we have updated now 96 children treated with tafenoquine. This is the ASMQ, the medication we have worked with for falciparum. We issued an informative note. It is a drug that is manufactured in Brazil by Biomanguinhos. It is to be used once a day instead of twice a day. It is also diluted in water, as well as the pediatric tafenoquine. If you have children or nieces or nephews, you know how difficult it is to administer drugs to children. So it is diluted in water, and it is totally Brazilian. This is the regarding the entomology. We have the stock of bed nets for hammocks and for beds, insecticide-treated bed nets. We used Antemprox, and we are trying to strengthen this system of a malaria vector portal to cross-reference with the human data, the environmental data, and do entomological surveillance and predictions.
Aí, esse aqui só para mostrar o mosquiteiro que a gente está usando
This
hoje, né,
is the bed net that we are using today. This is the blue net that you can see in the picture. This is a health education and social communication examples. Last year, we did some webinars. Dr. Claudio participated in honor of Dr. Pedro Taui. We have infographics that we launch that showing the malaria infection per states, per special areas. This is the website of the ministry. And here because of the World Malaria Day, we created several content for social media. We have the supporters project since 2012. Currently, we have 26 supporters that are in the municipalities supporting regarding epidemiology, data analysis. They support the malaria program, so this is the strength of our national program. And we also have the course on malaria leadership. Pablo is the manager of our leadership course. We have already had 6 editions, and the last one was in the priority indigenous special health district in Brasilia, including Dr. Claudio, Dr. Aniele, Dr. Fatima. These are the joint workshops on malaria elimination. We're going to have 3 others this year where we try to work on all of the axes of the program so that we can have for the municipality to understand and the goals and have the goals to be fulfilled with the support of the Ministry of Health. We have a plan for falciparum, which we are trying to focus attention in municipalities that have a higher percentage of Plasmodium falciparum. Here we have Dr. Marcos Bolos, Dr. Pablo Secato. We did the stratification, and now we're working more strategically with these municipalities with good results. We had workshop in Calçoene, in Amapá, Porto Velho, in Rondônia, in Humaitá, in Amapá as well, and also in the Pirahã territory. These are agreements that we have directly with the Secretariat of Indigenous Health. We have already 2 plans that are undergoing in a partnership with the municipalities, the states, the health districts. This is in the Yanomami territory. And, well, 2 weeks ago, we started the subnational verification. So we started working with good practices, seals, stamps. We are writing a guideline so that we have 5,770 municipalities in Brazil. Today we have autochthonous cases in 270 municipalities. 80% are in 25 municipalities. So there's a lot of municipalities in the Amazon region that don't have malaria anymore. So we want the health secretary to have a baseline on diagnosis and treatment, because if he finds someone with malaria, they will know what to do. These are some photos of our face-to-face meeting we had in 2024, the national meeting, the last national malaria meeting. This was in the Yanomami territory, and these are very interesting photos. G6PD being administered on this wooden plate, because in many places you're not going to have a metal counter to work on. Last week we have the presentation of the Bill of Law to make the National Program of Prevention and Control of Malaria into a state policy, regardless of who is in the government. And I would like to thank our whole team. Representative Derinaldo is in the leadership of this program, and we're trying to work now on environmental licensing to raise funds. I wish it becomes a law. I wish it becomes a policy, and then we can have more funding for the National Malaria Program to give us more autonomy, and so we can walk towards elimination. That is a photo that I took at the Rio Negro in the municipality of Barcelos. I always add it to my presentations because it's beautiful. Thank you very much to everyone who welcomed me to the malaria program. I'm not going to name names, but please feel hugged and thanked. Thank you.
Bom, a mim coube chamar o segundo palestrante.
Well, it's my job now to invite the second speaker, Pablo Secato Fontoura. Pablo is a biomedic. He is a master and doctor at the Science and Biology School of the University of São Paulo. He studied in the School of Public Health of the University of Harvard and in the Institute of Tropical Medicine of Lisbon, and he's the technical advisor of the National Program of Malaria Control and the coordination of malaria elimination, in addition to being one of the 3 amazing candidates to the Ruth Nussensweig Medal. Thank you, Dr. Claudio.
Bom, boa tarde a todas e a
Good
todos.
afternoon, ladies and gentlemen, once again. Thank you very much for the presentation, the introduction. I will talk about the program, continuing the presentation of our coordinator, Alexander. I will speak specifically about the scientific research and how the program has been absorbing these innovations and discussing them with you. And I will mention what we have been working with and the challenges that we've been having, because you're part of this process.
It is a dynamic process. We need to have this overarching vision within our coordinational strategy. And this is the context. This is the Brazilian context. Brazilian malaria is highly clusterized. About 80% of our burden is concentrated in 26 municipalities. We call these the control municipalities. In terms of eradication, we have to reach about 5% of all of our municipalities. To those who don't work with malaria, you would say, oh, so it's not an issue. It's very specific. But this process is highly dynamic. And of course, post-elimination, this needs to be further discussed. I don't know if anyone's been through this process already, maybe at a lower scale, not such on a macro national scale. Of course, to think about the elimination of malaria in Brazil in the context of its diversity, there's no way to leave it only in the technical side. We must think about the political and social economic implications of it. Like I said, many of our high malaria municipalities are also highly vulnerable, especially environmentally speaking. So this is a very interesting interface for us to work with, to think about that not just the biological side is important, there's the post-elimination as well. This is an important context for us to have as a research point. For malaria, there's no way to talk about malaria and add it as a public policy without including the Brazilian single health system, or SUS. It must be led at the state and municipal level. These are the actors who will actually conduct implementation. Those who will actually put these things into practice are not people who on computers in the Ministry of Health, but local action at the state and municipal level. So this context of optimizing resources, optimizing a lot of things, it must not be understood as a reduction. Sometimes it's mistaken for it. Another important context is this paradigm shift, disease versus infection. We must be working with this. We'll discuss this further later on. I don't know if you agree, but one concept that we will need to review or at least improve at the national level is the Amazon region and the outside Amazon. When you elevate that to the transmission level, almost 70% of municipalities have these transmissional situations. Sometimes we're talking about Amazon and we're talking about the whole Amazon. This is not the context that we see locally. Like I said, there are many populations that are currently vulnerable. So this is a context that we need to be leading at the social and pragmatic levels. Alex also mentioned this. In the context of eliminating malaria, in the stratification, which is of course theoretical in the sense of developing the activities, but we must also develop these special areas, which are our priorities in the context of malaria. And the translation of science into public policy. We know that the response time, that the states and municipalities want something much more immediate. And we know that research takes its time, and it is, of course, necessary. But usually they want innovation immediately. I get asked this very, very frequently. Oh, another smear test? When is the innovation going to come? So this is a dynamic that we need to work with. So this is a dynamic process. We usually talk about the priorities of the national program. Priority, well, that has many different pathways, not just in terms of the responses of the program, but it has a financial side. It involves many fields, and this was also dynamic. You've probably been through the control stage, where Brazil was treated as a control country, so the strategies were different, resources were different, and even the malaria transmission dynamics were also different. As per the sciences of elimination, we need innovation. We've been discussing this for 3 days now. This context of having innovation to talk about this paradigm shift, of what we need to actually eliminate malaria in this country, not just in the Amazon. And like I said, the prevention and reintroduction of the parasite. This is important for us to think about, especially in the border regions. This is just to show that this is a dynamic process, and it also involves academia. Academia is very much a part of innovation, obviously. It is excellent, and it is crucial as well for any elimination process. In my opinion, any field can work with malaria. Whatever is your training, there are fields for you to work with in malaria.
Acredito não, né? Acredito. Que aquele gráfico que a gente vê de serrote, né? Muitas vezes a gente fala,
saw graph, you say, oh, there's a discontinuity of action, but there are so many factors involved. Often we're not able to translate these as concepts to work with. So there are many factors involved beyond just the biological one, which is the one that we discuss the most sometimes. So scientific evidence is not a prerogative of the program to exclude any of these fields. We work with all of them. So it is not about prioritizing one or the other, but the opposite. The program's actions are based on every single one of these. And of course, that provides with the support for us to make the proper decisions. Your production is, of course, utilized to make decisions in all stages. So I try not to be too repetitive. I'll talk about the advances and opportunities. As we've been discussing, the Plasmodium vivax and the radical cure, with this tool which is formidable for pharmacovigilance, pharmacosurveillance rather, and showcase other opportunities for treatment, as it was shown in papers here in Brazil. We have excellent work developed here. I think Natalia is here. So provoke us, send emails, set up meetings in order for us to continue discussing these. There's a lot for us to do, and we need to take every opportunity to collaborate. So like Alessandro said, this is a great innovation, but we can also utilize this tool in other opportunities. And here, also a provocation, and see what you think. Use tafenoquine as another modality of treatment, like ACT derivatives. We need to move forward. The hypnozoids, as an example, as we see oftentimes in the field, everything's a relapse. So in addition to the epidemiological criteria, we have the biomarkers to identify these possible relapses, as we call them today. In the vectorial control side, like I said, I'll just mention a few examples. We've moved forward as well with our groups and partners. We have this opportunity of conducting tests. This provided us with a basis for us to construct the MILT, and this is scientific data that provides a basis to the decision-making process of the ministry. The insecticides utilized here, this is all discussed at the ministry level, and it guides our policies. We also have opportunities in terms of entomological surveillance, as we talked about. This is just an example in terms of what we can think about to optimize our epidemiological surveillance. Over 70% of Amazonian municipalities don't have autochthonous transmission, and this was due to the mobilization of the field. What can we do in the post-elimination to think about the entomology of the field? there's always room to improve. So new opportunities, like it was showcased before, Bento, the strategies that are utilized in other countries, but we need to push here in Brazil. And it is a huge challenge for entomology. There's a great image, high exposure with many breeding sites. Often people don't have the homes with alternatives, so we need alternatives for different scenarios in Brazil. Like Alexander showcased, we have this advance in testing, but there are things that we still need to answer. We have factors to standardize, all in order to improve the work that we've already been doing, in the case of quick testing especially. So what we've been working on in terms of the reservoirs, the transmission dynamics, this is something that keeps me up at night. The symptomatic and asymptomatic transmission, it oftentimes generates issues at the base. And people say, oh, there's malaria because there's a lot of asymptomatic and subclinical levels. People may hear this, or maybe there was one paper who said this very broadly. So we need to better define this information, in my opinion. And diagnosis and elimination, what we need in order to move forward in that area. And what can the single health system address or not address?
Os cenários, a gente vem trabalhando também.
The scenarios, we've been working in order to do stratification or micro-stratification, as Barro has been defending, identifying not just the municipalities, but the locations within the municipalities. This is just an example. Break that idea that there's only one strategy. Wherever we have malaria, you have to expand our diagnosis. Where you have more focal malaria, you can do more directed active research, in the sense of also doing entomological surveillance, vectorial control. So we've been working on that perspective, on micro planning. This can also be a very interesting line of research. In terms of recommendations, these scenarios can really help, as the WHO defends. We need to move forward in adapting these to the local realities, health promotion as well, volunteering. I believe this is key in areas where it's much harder to maintain teams, some areas that are harder to reach. So it's really essential to work in partnership with these communities. We showcase here how difficult it is for us to enact alternative solutions. We were discussing this earlier. These scenarios and active searches, thinking about the elimination of falciparum as a first goal to strive for, would that be viable, feasible, cost-effective? I don't think it's here, but no, didn't add it. The checking of the anti-malarial resistance, and we also need to move forward in that, in the research questions involved in that. So I don't know if you agree, but in my opinion, this is a huge bottleneck. In the sense of Vivax development, the imported malaria as well. We need to think about tools that we can utilize in these cases for the immune prevention of malaria. It's a broad field that we need to push forward. The borders are very diverse. Each one has their own specificities. So, climate and malaria is also something to consider. Often we come to the base and we start talking in a very superficial manner, and we need to better understand this context and find out how we can work in partnership with SUS to mitigate this. Zoonotic malaria and its implication for the malaria elimination in Brazil, another extremely relevant theme, and we are developing it. I left this last, governance and policy, for us to think about this evolution. I was talking about this with Felipe. I think it's where we know the least. Oh, I think malaria is over in this place because of this. Oh, I think they don't do anything else after eliminating malaria. So lots of thoughts, and we need to advance in terms of understanding what worked and what didn't work in order for us to put this into practice and better understand what was done to eliminate malaria anywhere. Oh, this complete deforestation and poisoning the land. So it's an important area for us to advance, especially qualitatively speaking, so that we don't make any mistakes that we've made in the past. So also to close and coming back, these are the fields within the program. When there's a public call, it's a great time for animosity. Oh, my line of research is not there, it's so important. And of course it is. Like I said, the prioritization within the program involves all of these areas. We had a meeting with the CT 2 years ago, the Department of Science and Technology, and we set around 6 to 7 lines. I had a meeting this year again, and they need to optimize the resources and think about one line. And I was like, one line for malaria? Yes, one line. There was only one space, and we had 7, 8. So we just added demand. So innovations to support the development of the elimination of malaria in Brazil. So that when there's resources, they will consult the technical side and they indicate lines. Oh, now we have X in terms of resources, so these are the lines we will dedicate ourselves to. Some lines, they need much more resources than others. So this was encompassed all under demand, and whenever there are resources, we can forward these to the priority lines. So everyone can work with malaria. Invite your partners beyond the health sector. This is very important. We need to move this conversation beyond the walls of the health sector. So reach out, get involved. If you go there, you will only get coffee and water, but you will be greeted warmly, of course, and we will discuss all of your ideas. Thank you so much.
Muito obrigado. Nós estamos com o tempo.
Thank you so much. Our time is short, but I'd just like to say that something that I miss in the program is the need, the necessity of eliminating transmission by falciparum. This is an urgent need.
Problema de resistência medicamentosa.
The pharmaceutical resistance is imminent. This is at the global level. So I believe that the adherence to the elimination, which is political in essence, but also technical, is crucially important. And I don't see a lot of conversation around this. So my recommendation is exactly that, for this topic to be raised at the peripheral levels and at the decision-making levels as well, at the state and municipalities. So this is my message. Any questions?
Marcos, please. First, I would like to congratulate the speakers for the presentations. I have a question. I'd like to mention 6 cases of plasmodium. Uh, where did these 6 cases come from? It is in the system. In 2025, we had 84 point something cases of percent of cases of VVEX, 14% of falciparum, and Valley has appeared in our system, 6 cases, but these are imported cases, Professor Marcos. We have a lot of movement among the countries over there, especially Guyana. Thank you very much, Dr. Alexander, Dr. Paulo. Thank you very much for your attention as well.